one-liner, and we'll be going back in the concepts from the medicine. We'll be going back towards pharmac and going back towards physio, and we're making sure that we'll be covering up, we'll be having a wholesome idea of what exactly happening inside your body. We'll start with the first statement here, the why conundrum for this particular session. And don't worry, this session will not be lasting for more than 5 or 10 minutes of time, right? We'll be keeping it as crisp and as small as possible. Okay. One-liner, and we'll be going back in. Okay. So we'll be starting with the first one-liner here, and that is the initial dose of AC inhibitors is reduced in patients with heart failure. This is a very important one-liner, guys, and we'll be talking about this one-liner in detail. First of all, why the initial dose of AC inhibitor is reduced in patients with heart failure. This is the why conundrum which we are going to be progressing up. Hi, Vengat. Hi, good evening. Okay. So we'll be discussing about why AC inhibitors dose must be reduced. The initial dose must be reduced in patients with heart failure. We'll be starting with the first question.
Progress.
Why is that? The reason is in terms of patient with heart failure. Here we'll be discussing with two different concepts. First is why this AC inhibitor dose is getting reduced in terms of heart failure. The second one is why AC inhibitors dose is reduced in patients, not in all the patients, only in patients with heart failure. We'll be targeting about two different concepts. Why this one-liner has been applicable only for heart failure patients, and the second one-liner, why this concept is primarily applicable for ACE inhibitors. ACE inhibitors are angiotensin converting enzyme inhibitors. Okay. The reason why it has been the dose is reduced is, first step, there will be hyperstimulation of RAAS system. What is this RAAS, guys? RAAS stands for renin angiotensin aldosterone system. Renin angiotensin aldosterone system. This is the reason why the dose of ACE inhibitors is getting reduced in patients with heart failure, because heart failure patients tend to have a hyperactive RAAS. That is the reason why ACE inhibitor dose is getting reduced. Again, we'll explain up why there is hyperstimulation of RAAS. I hope you understand what exactly is this why conundrum right now. So why is there a hyperstimulation of RAAS? It's because in patients with heart failure, there will be decreased cardiac output. The cardiac output is getting compromised. That is the concept of heart failure. Because of decreased cardiac output, there will be decreased renal blood flow, because the amount of blood which is coming out from the heart is getting decreased, which in turn will be decreasing the blood which is supplying to the kidneys. As we know, the major amount of blood which is coming out from the heart is going to be supplied up towards the kidney. So the renal blood flow or the renal blood pressure is going to be decreased. The next step, because there is decreased renal blood flow, there will be activation of renin angiotensin aldosterone system, because we already know whenever the renal blood flow is getting decreased, there will be activation of renin system, which is sensed by the juxtaglomerular cells. Juxtaglomerular cells are those cells which are present nearby the glomerulus, which will sense that there is a decreased blood flow towards the kidney, which will activate renin angiotensin. By the activation of RAAS system, there will be vasoconstriction and increased blood volume. By activation of RAAS system, there will be vasoconstriction and increased blood volume. This is a compensatory mechanism in a patient with heart failure. I will recap it. In patients with heart failure, there will be decreased cardiac output. When the cardiac output is getting decreased, there will be decreased blood supply to the kidney. When the renal blood flow is getting decreased, there will be sensing by the juxtaglomerular cells, which will activate renin angiotensin aldosterone system. Because of this hyperactivation of RAAS, which is happening in terms of heart failure, there is a link between AC inhibitor drug dose and a patient with heart failure. The second step is, whenever there is activation of RAAS, there will be, of course, what is R stands for? R stands for renin. So there will be increased renin levels. Okay. We'll discuss about why is there this kind of increased renin levels. Why are we talking about hyperactivation of RAAS? What's the difference between a normal patient and a heart failure patient? In a normal patient, there will be activation of RAAS. In heart failure patient, there will be hyperactivation of RAAS. Why is there a difference between these two different cases? The reason is, in terms of chronic heart failure, there will be persistent decrease in the cardiac output. Hi, Tino, good evening. Okay. There will be a persistent decrease in the cardiac output because that's the concept of heart failure. Because of continuous decrease in the cardiac output, there will be constant activation of RAAS. Whenever the RAAS is getting constantly activated, even if it is getting activated, the increase in blood volume, the vasoconstriction cannot increase the cardiac output back. That is the reason why there will be a consistent increase in the plasma renin activity. Again, a small recap of this why conundrum, guys. Why the initial dose of ACE inhibitors is reduced in patients with heart failure? Because of increased PRA. PRA here stands for plasma renin activity. PRA stands for plasma renin activity. Is it good? Good. Now we'll proceed on further. Let's look into why the initial dose of ACE inhibitors reduced in patients with heart failure. Again, the same one-liner, but we'll be concentrating more on the ACE inhibitor right now. Okay, why not the other drug doses? Why are we talking a lot about the ACE inhibitor primarily? We'll be discussing that. Because this ACE inhibitor, whenever it is given at normal doses, again, we'll be discussing about this why, guys, right? Again, we'll be discussing about this why. Why ACE inhibitors dose is getting reduced in patients with heart failure? Because when it is given at normal or the usual doses, patients might land up in first dose hypotension. What exactly is this first dose hypotension? Why is there a development of first dose hypotension? Not in all patients, only in patients with heart failure, or in some patients we can see this first dose effect. And why is that? Again, we'll be discussing about this question. Why is there a development of first dose hypotension whenever ACE inhibitor is started at usual doses in patients with heart failure? The reason is, first of all, in patients with heart failure or in patients who are under chronic use with diuretics, there will be their blood pressure will be primarily dependent on renin, angiotensin, aldosterone system. Yes, good, Dr. Tamil. It's because of postural hyper. It's a type of postural hypotension. There's first dose, seen only with the first dose, not after on a consequent doses. It will not be seen. We'll be discussing about that point. The second point is the BP is primarily dependent on renin, angiotensin, aldosterone system because there is a decrease in blood volume, there is a decrease in the vasoconstrictive effects. So get it back, there will be reactivation of renin, angiotensin, aldosterone system, and the blood pressure will be primarily dependent on this RAS system activity. So what happens? Because of this hyperdependency on RAS, there will be increased PRA. PRA stands for plasma renin activity. PRA stands for plasma renin activity. Now, because of this plasma renin activity, when ACE inhibitor is started at usual doses, it might induce a sudden decrease in the blood pressure, which will not be seen when ACE inhibitor are started at lower doses. Again, so what exactly is that conundrum here? The initial dose of ACE inhibitor is reduced in patients with heart failure. Why the dose is getting reduced? Because when it is given at normal doses, it might produce first dose hypotension. Why is there a first dose hypotension? Because there will be increased plasma renin activity. In patients with high plasma renin activity, when you administer ACE inhibitor at high doses, they might land up in postural hypotension, which will not be seen when it is started at lower doses. Again, we'll come up with the next question. Why is this particular phenomena? Why this, when given at low doses, why is it not producing postural hypotension? We'll be discussing about this why conundrum here. When you start ACE inhibitor at extremely low doses, not at usual doses, subtherapeutic doses, there will not be a sudden decrease in the blood pressure. There will be a gradual decrease in the blood pressure because you're starting at lower doses. When there is a gradual decrease in the blood pressure, the compensatory sympathetic activity will get reactivated. Because of this, the hypotension will not be happening. The hypotension will never be happening. That will be counteracted by the sympathetic activity. Just a 2-second recap of what we have discussed till now, my dears. The initial dose of ACE inhibitor is reduced. It is not a normal dose. We administer a subtherapeutic dose in a patient with heart failure. Why is that? Because heart failure patients, they will be having increased plasma renin activity. Why is there a plasma renin activity? Because heart failure patients are more having or having a hyperstimulation of RAS system. The second one, why the initial dose of ACE inhibitor are getting reduced? Because what will happen when you give it normal doses, there will be first dose hypotension. And why is there development of first order hypotension? Again, because of increased plasma renin activity. When you give it normal doses, there will be a sudden drop in the blood pressure, which the patient cannot tolerate. So that's the reason why we have to start at low doses. Why at low doses it is not developing? Because when you start at low doses, there will be a decrease in the blood pressure, but the compensatory mechanism, sympathetic activity, will prevent the further drop. It will prevent the hypotension from happening. It will just decrease the blood pressure to a particular level and makes it to maintain in that particular level, preventing the patient from landing up in first dose hypotension. Okay. This is the beautiful concept of the Y conundrum, guys, right? So we have discussed about an important one-liner. What is the one-liner? The initial dose of ACE inhibitors are reduced in patients with heart failure. And we have discussed about all the reasons why is this particular concept, why is this particular one-liner very much important in clinical practice. That is also one of the reasons why, see, long before JNC 8 came, diuretics were the first-line therapy of choice for a patient with heart failure. Okay, but later on, or especially for hypertension also, diuretics were the first line therapy for a patient with hypertension. But after around 2007, 2008, the ACE inhibitors has been changed as the first line therapy of choice for a patient with hypertension. So what happened was, whenever we are prescribing diuretic for the patient comes back for the follow-up, and we say that the treatment process has been changed. ACE inhibitor is currently the treatment of choice. So I'm going to be changing you with newer ACE inhibitor called as enalapril. When you prescribe the enalapril for the patient, a lot of the patients are reporting back to us and telling the complaint that, sir, after the tablet which you have given, we started landing up in severe giddiness. I think the drug dose is wrong. Please change me back to the same old hydrochlorothiazide. This was the most practical issue which has happened when there was a shift over from diuretics towards ACE inhibitors or ARBs. So that was the reason why, because ACE inhibitors, whenever it is given in a patient who are already under diuretic use, they were more prone to land up in first dose hypotension. Why is there a concept of hypotension? Because diuretics, patients will be more dependent on RAAS system. When you block the RAAS system, sudden drop in the blood pressure. Compensatory mechanisms, we have to wait till the compensatory mechanisms kick in. That's the reason we have to start at low doses. Once the compensatory mechanisms kick in, we can increase the dose slightly towards the same old therapeutic drug dose. This is the concept of today's Y conundrum, guys. I hope we have explained about an important concept in as much short as possible, and we'll meet up in one more Y conundrum as early as possible. Bye-bye. If you have any issues, if you have any doubts, please put up in the chat box. Very much happy to answer. Good night.
Record